So just to start with, a few housekeeping rules. So hopefully, as everybody's come into the meeting, you should be on mute, but if you can keep yourselves on mute throughout, that would be really helpful. This session is going to be recorded so that it's available later, just so that you're aware. And just to give you an idea of the plan for the evening, this is going to be a very interactive session, and it's a really good opportunity to ask questions, and also questions will be asked of the audience. So we're going to do this via the chat box. So as questions come up, but also if there's any questions that you've got that you want to ask, if you just type them in the chat box, we'll have myself and my colleague Lisa, who will be keeping an eye on it, and we'll read out all the questions. We'll read them out anonymously unless there's something very specific that people, ask for otherwise. So please do, make the most of that chat box function and pop your questions in there. Just to reiterate, I'm Shani. So my role in the faculty is I'm the first 5 lead. So we help to organise these events, usually around every 3 months, although a slightly different pattern at the moment with COVID. And I'll introduce my colleague Lisa Collins, who's also part of our faculty board. So Lisa, I'll hand over to you.
Hello everyone, thank you Shani. So yes, I'm Lisa, I'm a GP, a locum GP, and just returned from maternity leave into this strange situation. So whilst I was on maternity leave, I did a diploma in clinical dermatology at Barts in London, and as part of that I shadowed Victoria Swell for the Rapid Access Skin Clinic, and I learned so much from her in those few hours. I thought she'd be perfect speaker for this talk. So I'll introduce Dr. Victoria Swell, consultant dermatologist at the Royal Free Hospital.
Thank you. And tonight the plan is we'll talk about dermatology emergencies, the top 5 lesions that I think would be useful for people to be familiar with, and then a little bit at the end about my experience of teledermatology. So the aims are to try and keep this practical, clinical and relevant. And hopefully you're aware of the resources I've put on the slide. So DermNet is a fabulous resource, really good for information for us and for patients, and it's got photos on it. The BAD, the British Association of Dermatologists, the website has patient information leaflets which can be printed off, so they're very useful. And then the PCDS is the Primary Care Dermatology Society, and that has, for example, algorithms on acne treatment which are useful. I've put my email address on there, so you'll feel free to contact me if that would be useful. And we're going to be accompanied by a few okapis, my favourite animal. Each okapi will signal the end of a section and is an opportunity for questions. So starting off with emergencies. And the term dermatology emergency provokes mirth certainly in cardiologists and heroic people like that. But there are dermatology emergencies, and it's important for us to recognise them. This is where I feel I have to justify my existence as a dermatologist, because people find the concept of an emergency spot quite amusing and say, well, why do you need on-call dermatology? Don't they just get better with a bit of cream? So I imagine that the cardiologists view us as sort of fairies dabbing on bits of cream and making people better. And then this image here on the bottom right is how the dermatologist feels when surrounded by a group of jeering, perhaps emergency specialists. Anyway, this is an emergency. And if you had a patient who looked like this, you would be phoning for an ambulance pretty quickly. This patient has toxic epidermal necrolysis, which is rare, but we do see it. Usually they present at about 5 to 5 on a Friday. And it's really bad news. It's got a really high mortality rate. And the concept of skin failure is one that applies to toxic epidermal necrolysis and to other conditions. And this is one of the conditions known as the SCAR, which is severe cutaneous adverse reactions. And there are several, and they all have slightly annoying acronyms. So there's SJS, or Stevens-Johnson. TEN, we talked about, toxic epidermal necrolysis. Then there's DRESS, which is a drug reaction with eosinophilia and fever and systemic symptoms. And then there's the really pithily titled acute generalized exanthematous pustulosis. Erythroderma is another one, when the skin becomes totally red. Many of these are triggered by drugs. Some of them are triggered by viral infection. And what do we mean by skin failure and erythroderma? So skin failure is the loss of skin function, and it's analogous to cardiac failure, respiratory failure, and so on. And in skin failure, the body can't regulate the temperature, so there's a risk of hypothermia. There's a risk of sepsis. Water and electrolyte balance goes wrong. Protein malabsorption can occur, and immunological surveillance doesn't work either. So people are really prone to severe overwhelming infection. In erythroderma, it's defined as the skin being 90% red or more. It's a serious systemic condition with a high mortality, and there are many possible causes for it. Perhaps the most common are eczema and psoriasis, but drug reaction is another one, and in fact any inflammatory dermatosis can cause it. And in erythroderma and skin failure, the skin's like a leaky radiator, so water leaks out, heat is lost. Homeostasis goes wrong. And erythroderma is easy to recognize in people with white skin, but very much harder in dark-skinned patients. So if somebody has had erythroderma before and they feel unwell, they're shivery, they maybe have a fever, and their skin is painful, then that needs to be taken seriously. And people with erythroderma generally need hospitalization. Here is one of the severe cutaneous adverse reactions. And you can see the picture on the bottom left, here we are. The lips are entirely ulcerated. Then there's big areas of denuded skin, and the skin is peeling off. So this is toxic epidermal necrolysis. It's almost always drug related. And we see sheets of desquamation. And this sign here, the Nikolsky sign, when you press with a finger on skin that appears to be normal, it comes off because it's not adherent to the dermis underneath it. It's always associated with mucosal involvement. It's more common in HIV, as many drug reactions are. And it has a very high mortality, even with very careful specialist intensive care treatment and multidisciplinary management. Not all drug eruptions are serious, obviously. Most of them are very mild. Any drug can cause any rash. And it makes it difficult sometimes, firstly, to make the diagnosis of a drug eruption. And secondly, to know whether it's due to a medication or whether it's due to a primary dermatosis. Because you can have lichenoid drug eruptions that mimic lichen planus, eczematous drug reactions that mimic eczema, and so on. And the history of the onset of the rash relative to the starting of the drug is important. And it can be from days to months after starting the drug. On average, it's about 7 to 10 days. And the pictures here, on the bottom one, we've got a photosensitive reaction. I think that was due to a thiazide diuretic. Then a pustular reaction in the middle, often, strangely, due to antibiotics, which is very counterintuitive. And then bottom right, we've got a vasculitis. I'm sure you all know what this is without any difficulty. So this is, oh, something's happened there. I don't quite know what. Sorry about that. So this is chronic plaque psoriasis. And the reason for showing it is that it is very, very different from this one, which is generalized pustular psoriasis. So this is a severe, it's an emergency dermatological condition. This one is phone the ambulance, intensive care monitoring. And this patient was our patient at the Royal Free a few years ago. She had a background of psoriasis and we didn't know what triggered it, but she became very, very unstable and she died, and she was only young, and it was terrible. So it is something to be taken very seriously. So not all dermatological emergencies are quite that emergency. Some of them require a phone call and an appointment in the emergency dermatology clinic, but perhaps not an ambulance. And here's one. So questions for you. How would you describe this patient's skin? How should she be investigated and managed? And which teams should be involved? So this is, as you probably know, eczema herpeticum. This is a severe, widespread or localized herpetic infection, usually HSV type 1, in a patient with a background of eczema. Can be in somebody with a background of another skin condition, but normally eczema. And it presents as a flare with painful skin and a fever, and these very characteristic monomorphic punched out lesions. And we need dermatology, we need ophthalmology, because one can get corneal scarring with this. And this is the same condition in a baby, showing those punched out lesions. This condition is important because there's the management needs careful thinking. So this is pyoderma gangrenosum, which is an extremely painful inflammatory ulceration of the skin. It's not infective, although it looks like an infection. Can be idiopathic, can be related to underlying medical conditions. And the critical thing with this is to avoid surgery. Sometimes they are repeatedly operated on to try and debride the area, and it gets worse. This condition as well, I've seen a few times recently. I wonder whether there's a pandemic association. So this is shingles. Not uncommon, and it's often diagnosed late. It's often diagnosed as a bacterial infection rather than a viral infection. The trick is to take a viral swab early, which is rapidly diagnostic. And it's important to think about it when somebody has a unilateral painful rash. So that's it for emergencies. So before we move on to the next section, perhaps if anybody has any questions, we could go through them. Chaps. I'm not sure I can see the chat, or can I? Or if there aren't any questions, we could go on.
Yeah, there's no questions in the chat, Dr. Swell. Oh, here we are. There's one here. Why do we need a swab from shingles?
If you are confident of the diagnosis, then you probably don't need a swab. it's a slightly sort of back to front thing. Sometimes the diagnosis can be missed, and I've seen it missed in intensive care a couple of times, and people can be treated either with topical steroids or intravenous steroids, and it's bad news because the infection flourishes, and in one case I've seen encephalitis resulting from it. So it's a sort of slightly back to front thing. If you know what the diagnosis is, you don't need a swab. It's just if you don't know what the diagnosis is, you need to think about the swab, which is a bit back to front, because if you think about it, then you know the diagnosis. It's just worth remembering shingles as a painful rash and a unilateral one often.
Okay, thank you. And another question, would necrotizing fasciitis go onto the surgical team?
Yes. And that's the one that does need rapid and immediate and aggressive debridement.
Okay, thank you. Another question about shingles. How often in your experience has it been bilateral?
I don't think I've seen it bilaterally. It's more commonly multidermatomal or widespread in immunosuppressed patients. So I've seen it reported in HIV or in people with other forms of immunosuppression, perhaps iatrogenically to do with malignancy, for example. So it's not common for it to be multidermatomal or bilateral.
Okay, thank you. Any more questions? No? Oh, here's one more. Going back to drug eruptions, how can a GP differentiate between toxic epidermal necrolysis and Stevens-Johnson syndrome? So both will need to be referred in, so they probably doesn't matter, is the inference there?
Yeah, it doesn't matter. They are essentially the same thing. We used to think that there was a spectrum that included both those conditions and erythema multiforme. We now believe that erythema multiforme is a separate condition, more likely to be triggered by viruses, like cold sores, for example, can trigger it. And it's not as severe, and it doesn't have the very extensive mucosal involvement. So the demarcation between Stevens-Johnson and toxic epidermal necrolysis refers to the amount of skin involvement, but both of them are bad news and both of them need referral. Okay. So the kind of practical point from all of those severe reactions is, if in doubt, refer.
Okay, thank
you. So they're hospital management cases. Shall we go on to the next?
Yes, I've got just a couple of questions about shingles, a few more about shingles. So firstly, should you treat it even if mild to prevent the risk of encephalitis? Then the second question is, if you have a clinical suspicion for shingles but you're not 100% sure, should you wait for the swab?
The first question, encephalitis is rare, but it's worth treating because anybody can get post-herpetic neuralgia, which is a really horrible condition. And so it's worth treating promptly to try and reduce the likelihood of that. Tell me again what the second question was. Oh, the swab, waiting for this. I would treat while waiting for the swab result, because acyclovir is a really safe drug. There are it's very rare that one has side effects from it. The wait for the viral swab isn't very long anyway. It's less than 24 hours. So I would swab and treat in that, but treat while waiting for the swab result, without waiting for the swab result.
Brilliant, thank you very much. That's all the questions from there.
Cool. Okay, so the next bit is lesions. I like this cartoon about the suspicious looking mole. And I'll talk about 6 lesions. I know the advanced billing was 5 lesions, but I thought actually 6 made the cut. So we have, I'm sure you know, this shiny lesion on the tip of the nose with this very pearly look to it is a basal cell carcinoma. We have an actinic keratosis on the nose, seborrheic keratosis, top right, dermatofibroma, squamous cell carcinoma, and melanoma, bottom right. And they're important because the cancers can be bad news, melanoma can be fatal, and the others can mimic the cancers. So here's a question about management. So here's a man with this changing lesion on the back. What's the differential diagnosis? How would you describe it? And what would you do? So this is an ulcerated melanoma and needs an urgent 2-week wait referral. So when we see these people in clinic, we remove the melanoma straight away. And the clues for this one being the melanoma is it's clearly very asymmetrical. So we've got this big nodule here, and then this macular component here. I'm thinking through the ABCDE criteria that help us to distinguish a benign mole from a melanoma. So A for asymmetry, B for border. The border's irregular, and you can see, particularly in this area, it seems that the pigment's sort of leaking into the skin. That's very characteristic for melanoma. C for colour, there's several colours within it. D for diameter, we don't have a scale on it, but it looks big. And then E, we've had a history that it's been evolving or changing. And a big ulcerated lesion like that is not ever going to be a benign lesion. Here's a woman with a lesion on the leg. How would you describe it? What is the differential and what would you do? So we've got a background, we haven't got much skin to look at, but we've got very pale skin with this dark lesion. And again, the surface here looks different. This is ulcerated again. It's asymmetrical because we've got this very dark area here and then paler reddish here. And there's a sort of bluish haze to it, which is something you see with dermoscopy as well. And that's a worrying feature in a pigmented lesion. So this is another melanoma. This is a nodular melanoma. They can be harder to diagnose. They're less clearly abnormal than a superficial spreading melanoma, which the first one was. And this one is shiny. It's lost the normal skin markings. So a normal mole has very fine little wrinkles on the surface like one's normal skin does. In a melanoma, the tumour is pushing up through the epidermis, and so you lose the normal little wrinkled markings. Melanomas also feel firm, in contrast to benign moles, which generally feel soft. Here are some more nodular melanomas. I think probably we wouldn't have trouble with that one. This one looks ulcerated. It looks very out of context on this patient's skin. This one's harder though, isn't it? And this one is amelanotic, meaning it doesn't have pigment in it. And these can be really hard to diagnose, and they're often diagnosed late. Little bit about who are the patients we need to think about as being most at risk of skin cancer. So out of Naomi Campbell and Ron from the Harry Potter films, who's most likely to get skin cancer? And can anyone, is it just me? This man really looks to me like a ready roasted chicken. So have a think about which cancers the ready roasted chicken patients are prone to. And then there's this guy here who's absolutely scarlet from sunburn and has lots of big moles. So what sort of skin cancers he most likely to get? The central panel here These pictures represent risk factors for all the types of skin cancer. So sunburn, sunbathing, fair skin. So people like poor old Ron there and this child, red hair, freckles, blue eyes, the very fairest end of the spectrum. We are most at risk of skin cancer. Bad sunburn with peeling, particularly with blistering, is a risk factor for any skin cancer type. And using artificial tanning beds is more carcinogenic than natural sunlight. For basal cell carcinoma, there aren't really any particular additional risk factors. For melanoma, the best way to get a melanoma is to have intermittent, intense sun exposure, which is, of course, what people who live in chilly Northern European countries tend to do. We go off and lie on the beach for 2 weeks a year, and that's a really good way of growing a melanoma, particularly if you get sunburnt, and particularly if you're very moly. So the more moles you have, and the more large moles you have, the greater your risk of melanoma. Also, if you have a family history of melanoma in a close relative. And the patient here on the bottom has atypical mole syndrome. It's really common, 2% of the population have it, and it increases your risk of melanoma. And then these pictures over on the right are the risk factors for squamous cell carcinoma. So if you're a ready roasted chicken and like really dedicating yourself to being sun tanned, then you're putting yourself at risk of SCC. Being old is a risk factor. And here's a kidney. So having organ transplants, it's the iatrogenic immunosuppression that increases the risk, particularly of squamous cell carcinoma. And you'll see that the people with the squamous cell carcinoma, they're all old and they're all fair skinned. And other immune suppression drugs taken for example, rheumatological disease, that also increases the risk of squamous cell carcinoma. It's worth remembering that not all pigmented lesions are melanocytic, and by melanocytic, we mean mole or melanoma. So here's a benign mole. It's small, it's symmetrical. This one has hairs in it, and that's a reassuring feature. So I'm not talking anymore about moles. We've talked about melanoma, but I'm going to talk about seborrheic keratosis and dermatofibroma. And just to mention in passing, probably every month or so, somebody comes up to the rapid access clinic with a suspicious mole that turns out to be an accessory nipple. That's always quite fun. Pigmented basal cell carcinoma needs treatment. This one will probably need Mohs surgery. And solar lentigo, these are benign, but they are an indication that somebody has had more sun than they are designed for. And particularly if you see, like this patient with multiple large solar lentigines over the upper back, we see that in people who've had sunburn during childhood. So that's a big pointer towards somebody who is at risk of skin cancer. And people, as you know, refer to the solar lentigo on the back of the hand as liver spots. Nothing to do with the liver, but everything to do with the sun. So how would you describe it, and what is the diagnosis? Seborrheic keratosis, super common. They increase in number after the age of 30. They can be skin colored to almost black. Characteristically, they have a stuck-on appearance, like a bit of old chewing gum stuck on the pavement. They can appear on the face and trunk and limbs, and usually do. And very typically, they're either keratotic, which means warty, they've got keratin on the surface, or they have a waxy feel to them. They can have more than one color, and they can look alarming, but they have zero malignant potential. They're nothing to do with moles or melanoma. And here are some more. Dermoscopy is a really useful adjunct in diagnosing seborrheic keratosis and distinguishing it from a melanocytic lesion. Even then, sometimes we're not sure and we have to excise lesions. But the dermoscopic images here, we can see these white areas known as milia-like cysts. This is keratin. And then the black areas here, this is also keratin, but this is open to the surface. It's not covered by any of the seborrheic keratosis. So these are called comedone-like openings. And I do a weekly rapid access skin cancer clinic, the one Lisa came to, and I facetiously refer to it as my seborrheic keratosis clinic because 2/3 of people who come to the clinic have seborrheic keratosis. And it's understandable, none of us wants to miss a melanoma, and the stakes are high because melanoma can finish you off. And the reason the clinic is full of seborrheic keratoses is that the ABCDE criteria are brilliant at helping us to distinguish a mole from a melanoma, but precisely no use at all in helping us distinguish a mole from a seborrheic keratosis. And there's a lot in common. If you look at this melanoma here, and then look at the seborrheic keratosis, if you apply the ABCDE criteria, then of course you're going to worry about the seborrheic keratosis. But I've been thinking about this the last few days, and the things that most help us to distinguish the two are the stuck-on nature of a seborrheic keratosis, like a bit of old chewing gum, and the fact that they're keratotic or waxy. So palpation's really, really important. And the other thing I alluded to earlier, can you see on the melanoma, it looks a bit as if you've dropped some ink onto a piece of blotting paper and it's sort of soaking into the paper with that sort of stain in the skin. Seborrheic keratosis doesn't do that, but it's a very typical feature of melanoma. Here is a different lesion. So we've got 3 50-year-old women with lesions on their legs. How would you describe them? What is the diagnosis and what needs to be done about them? So these are dermatofibromas, really common, particularly in women. We see them typically on the leg and sometimes around the shoulder girdle as well. And these are firm and they feel exactly like a lentil in the skin. My colleagues always taunt me because I compare skin conditions to items of food because I quite like food. But these are really, if you think lentil, this is exactly what they feel like in the skin. And the reason they come to the rapid access clinic is that they can look very dark, they can look strange, they can be any colour really, from pale to very, very dark. Characteristically, when you gently squeeze the skin around them, the surface of the dermatofibroma dimples because it's tethered to the epidermis. These may follow insect bites. They're of no consequence. They don't need any treatment. Moving on to another diagnosis. So we've got an older patient with multiple dry areas on the face and scalp. And so we can see all these pictures show very fair skin, sun damage with blotchy pigmentation, and then these erythematous keratotic plaques on the skin. So these are actinic keratoses, super common. And there's another, 2 food comparisons on one slide. So these, jumping to the bottom of the slide, these feel like Rice Krispies on the skin. And dermatologists, we're very friendly people. We like to stroke our patients. And it's the best way of identifying an actinic keratosis. So they're not lumpy. They're flattish lesions, but they feel rough when you touch them. So we see them in fair-skinned older people who've had dedicated years in the sun, our ready roasted chicken cohort, commonly on the face, the scalp, tops of the ears, tops of the arms, dorsal hands, and they're almost always multiple. They're very social creatures, actinic keratoses, and we refer to it as field change. So often in a bald-headed man, the whole scalp will feel rough and dry. Each individual keratosis has a very low risk of turning into a squamous cell carcinoma, but if you have lots of them, the risk goes up and up. And these are scaly, there's no substance to them, and it's that that distinguishes them from a squamous cell carcinoma. Moving on to, here's another older patient, fair skin, and this patient has a lump, and this lump is keratotic. We can see that thick layer of keratin on the surface. What is the differential? How would you describe it? And what would you do? So this is squamous cell carcinoma. And these can be keratotic and or ulcerated. So all of these ones, or at least this one and this one, have areas of ulceration. And there's keratin on the surface as well. Almost always the background skin will be fair and sun damaged, and it'll be our older sun damaged patients. There's a super high risk in people who've had organ transplants because of the immune suppression. And what distinguishes a squamous cell carcinoma from an actinic keratosis is that this is a lump you can feel between finger and thumb. These grow fast and they can be tender. And those features distinguish it from this lesion. So, what is the description? What is the differential? What would you do? So these are basal cell carcinomas. Really, really common. We see dozens every week. It's the commonest human cancer of all. And these, I think, are rather beautiful. They have this pearly, translucent look to them with branching blood vessels on the surface. Often they have a rolled border like this one here. They have, for practical purposes, no metastatic potential, and they grow very slowly. And what people say is it keeps scabbing, but never quite heals. So if somebody says that, you know what the diagnosis is pretty much. So that's it for lesions. So the next Okapi says, any questions on lesions? And at this point, when I do talks, I usually invite my colleagues to join me in the rapid access clinic, but we'll have to wait until the pandemic is better behaved for that. But you are most welcome to join me.
Brilliant, thanks, Tor. I'll start off, we had another question on the lesion section. So somebody said, how would you differentiate between nodular melanoma and a pyogenic granuloma?
It's a really good question. You can't. If there's a history of trauma or the patient is pregnant, then it makes it more likely to be a pyogenic granuloma, but we remove them urgently because they might be a melanoma. So you can't distinguish them.
And we had another question going back to shingles. Somebody asked, GP's favourite, I think. So if a pregnant woman has been in contact with a patient with shingles, should we check serology to decide if she would benefit from immunoglobulins? And how quickly would we test her?
Do you know what I do is phone the virologist for advice, quite honestly. I guess you probably know more than I do about that. I can't remember. I would honestly phone the virologist. Or what would anybody else do? What's the right thing to do? Who can remember? Shall we phone a friend?
Yeah, does anybody want to either type in the chat box or feel free to unmute yourself?
Yes.
So somebody said here they'd usually discuss with gynae.
Yeah, I think it's reasonable to do that.
And somebody else said that they check serology. And then another option here is they would send to maternity to do the immunoglobulins, and then that would give the answer. Somebody else has said if they have chicken pox, no need to do anything. Discuss with micro, request serology. Someone else here has said if they haven't had a clear history of chicken pox, they would start acyclovir. If they have, then they would do bloods first. And then I think the consensus again, if in doubt, get serology. Yeah. Any more questions on the lesions section before we move on?
Or on shingles.
Yeah, or shingles. Okay, so we've got a few more comments coming through about shingles, people saying that they would discuss with gynae. Somebody recently had a case, the person was over 20 weeks pregnant, and they had negative serology, and they're exposed to a child with chicken pox, so they discussed it with virology, and then that patient had acyclovir. Somebody else has asked, do you prescribe antiviral even after 72 hours in shingles?
Yes, I would. Again, because the post-herpetic neuralgia can be so unpleasant, I think the antivirals are going to be less effective the later they're given, but they may still have some effect. And as they're generally safe and well-tolerated drugs, I think it's reasonable to.
Oh, somebody's asked here, I don't know if this is part of the same question or something new. I think they're asking, is ductate psoriasis an emergency?
It's not an emergency. People don't get ill with it, but it's something we tend to see as quickly as we can, because it generally responds very well to light treatment. So we'll give people UVB. We'll also check an ASOT and do a throat swab and treat if there's any streptococcal infection that's active. So it's not an emergency, but it's one to investigate and to treat promptly.
Brilliant, thanks. I think that's all our questions, so we can move on to the next section.
So, next section is probably shorter than the others. This is teledermatology. So the world has changed, hasn't it, in the last few months? We were doing teledermatology pre-COVID, but that's ramped up a bit now. So the theory is that it's the use of technology for remote diagnosis and management. It avoids the need for patient travel, quick and efficient, makes best use of limited resources, and there can be a good learning role with rapid feedback to the referrer and the opportunity to strengthen links between primary and secondary care. Dermatology is very visual, so it lends itself to technology, and obviously it's safer for everybody during COVID. However, and I should stress that the views expressed here are my own. NHS technology, certainly at the Royal Free, is utterly antiquated. We're pretty much using mainframe computers peddled by us. We have to use different programs, and none of them talk to each other. The pathways and processes they're constantly in evolution, and it's not entirely clear sometimes what the pathway is. Often the image quality is insufficient to make a diagnosis, and sometimes clinical information is insufficient as well. We're auditing our teledermatology at the moment, and my colleagues informed me today that 20% of teledermatology referrals don't have any images at all. I think that's an administrative sort of hiccup, but it makes it difficult to diagnose things. It's quite time consuming. So actually, although it's meant to save time, it seems to take a lot of time. And whenever it's been looked at in any setting at all, it actually increases referrals to secondary care rather than reducing them. From our point of view as well, it's frustrating because we can't carry out a full skin examination and there's usually no dermoscopy. And coming back to the importance of the full skin examination, we did a study a few years ago of patients in the rapid access clinic, and a third of the patients coming to the clinic had an additional diagnosis of importance, and that included skin cancers, it included melanomas, because we're looking at a high risk population fairly much by definition. And patient history is very important in dermatology. So I've given the game away on the right here with the line, it keeps scabbing and never quite heals. Hopefully you can remember that that's a basal cell carcinoma. But how about this one? When somebody comes in and says, it's my skin. And as a dermatologist, it's kind of quite tempting to say, well, you're in the right clinic or something like that. But there is a diagnosis that goes with that sentence. I wonder if anyone knows what it is. It's acne. And my personal theory is that people with acne just don't like saying, I've got acne. And I think that may be the issue. With lesions, the history is really, really important, which is why we tend not to like doing corridor consultations and having a quick look at somebody's mole, for example. So we need to know in a telederm referral, where is it? How long has it been there? Has it changed? When did it change? Was there any trigger to the change, such as trauma? Have they had 17 melanomas beforehand? Are they on immune suppression medication, for example? What the referrer thinks the diagnosis is and how much sun the patient has had and how sun damaged they are. And with images, quite a lot of them, as I said, 20% don't have images. For those that do, quite often, again, the site on the photograph doesn't match the site described in the letter. And most of the photos aren't labeled with the patient's name or NHS number. So we're never entirely sure whether the right picture is going with the right letter. Often the images are out of focus. And it's useful for us to see other lesions so that we can see the index lesion in context. So here's a real example. The referral letter was really brilliant. There was lots and lots of detail. So it described multiple moles, recent change to the one photographed, a little bit itchy but no bleeding. Previous moles were removed because of bleeding. Described it as a 2 centimeter irregular mole with a stuck-on appearance, with some hyperpigmentation and neovascularization within it, and 3 satellite lesions. With that history, one will be really worried. But then I looked at the lesion, and what do you think the diagnosis is? Won't wait for the chat, but this is a good old seborrheic keratosis. And it's a bit like the question about, do you swab if you know it's shingles? If you know it's a seborrheic keratosis, then you know not to be worried by what you're seeing, because the criteria that make a lesion worrying if it is a mole are entirely non-worrying for a seborrheic keratosis. So if you substitute the word seborrheic keratosis for mole in the history, then you're happy. One question here though, previous moles removed for bleeding. You know, why Why were they bleeding? Were they sent for pathology? Were they moles? And if you think about, these are satellite lesions, then that's worrying. You think about a melanoma producing satellite lesions. If you think about them as smaller seborrheic keratoses with a similar color, then you're happy and relaxed about it. Here is another example. The letter described moles and said the patient was worried by itching. How worried are dermatologists by itchy moles? We're not worried. We're not bothered by itch. If you're a mole, it's okay. Generally because they're seborrheic keratoses. But this one was difficult to comment on. I wasn't sure where they were. There was no scale to give any idea of how big the moles were. I didn't know whether they'd changed. The image is nicely in focus, but a little bit distant. And we don't know anything about the skin elsewhere, how much sun exposure the patient has had, whether there's any personal or family history of melanoma, for example. And this one was interesting. So really detailed history about lesion A. And I think the trigger for the referral was that it had bled and the patient had a previous history of melanoma. So the level of concern was higher. I thought that looked tiny. It's a little bit out of focus, but I thought it was a harmless, non-viral little warty thing. But then I saw that thing and wondered whether it could be a basal cell carcinoma. So it's an example of an incidental finding. So I returned the comment to ask for more information about that lesion. This one I was delighted by. Really nice photo and great history that the lesion appeared 1 week previously. What is the diagnosis? Haven't got time to wait for the chat. So this is called talon noir, and I only discovered recently that it means black heel. It's normally seen in people who do lots of running or walking on the heel, and it's due to friction-induced little tiny bleed in the surface of the skin. And they look very dark and they can look scary, but they come on very, very rapidly. So no melanoma is going to appear after a run, for example, that quickly. Dermoscopy is useful for these. What I like to do is to just pare them off very gently in the clinic, and then you can cure your patient instantly, which is splendid. Doesn't happen all that often. This was a nice one. Again, really good history, really detailed, and beautiful pictures of this young woman with these little tiny papules on the back of the hands. So this is a rare condition, I think. We're waiting for the patient to come so we can biopsy her. But I think this is lichen nitidus, which may be a variant of lichen planus. So this was a nice one as well. So 65-year-old lady with a new itchy rash. How would you diagnose that one? And I thought this was lichen planus. And it's got very characteristic purplish colour on the medial aspect of the wrist. And also involvement of the axillae is characteristic. And these improve with super potent topical steroids. So this was another one where slightly blurry image, and the letter and the photo were discordant for sight. And I think that's the last of the Telederm ones. Oh no, there's these ones. How do you diagnose these ones? I'm being facetious, obviously. This is a Loch Ness Monster, and this is a UFO. Some of the images could well be a Loch Ness Monster or a UFO. And that is the final slide. Here is our final okapi of the evening. Would anyone like to ask any questions?
So I've got a question. Can you please comment on what platform you are using for your teledermatology? For example, ERS or advice and guidance or something else?
I think advice and guidance. There's been all sorts of talk about all sorts of different platforms. We're using advice and guidance at the moment.
Okay, thank you. And what's the best way to get training in dermoscopy?
There are regular courses run by the Primary Care Dermatology Society. There is a course run by the St. John's Institute going on here, strange lines appearing on the talk. There's a course in October run by the St. John's Institute of Dermatology. So that might be the next one. And that's a virtual one by Zoom.
Fantastic, thank you.
Or come to a clinic. When the pandemic permits, come and join us in the clinic.
Thank you. And regarding actinic keratoses, what treatment is advised in primary care, and would we be expected to refer to dermatology?
To answer the second question first, there's no need to refer unless you're worried or the patient's not getting better. The treatment depends on what the patient has had before in terms of treatment, how many actinic keratoses they have. If they're in general, I tend to use Efudix cream if somebody has multiple actinic keratoses, and cryotherapy if they have only one or two. They don't necessarily need treatment either. So if somebody's not troubled by them, if they're not symptomatic and they're not terribly bad, we advise sun protection and moisturizer because they can go away. The early actinic keratoses can resolve spontaneously.
Great. And again about dermatoscopes, would you recommend for GPs that we need good quality dermatoscopes, or can we go for something more reasonably priced like Amazon?
They are really expensive, aren't they? I'm not sure how to answer that really. There's also a question as to whether it's kind of necessary or a good thing for GPs to use dermoscopy anyway. And I think it depends on how happy you are using it and how many lesions you see. I haven't tried the dermatoscopes that aren't wildly expensive actually, so I don't know. But in fact, I have tried one and it was really rubbish. I don't have enough experience of a range of them to answer that properly, apart from limited experience of borrowing one that I couldn't make any sense of. So I think it may be a case of paying the money.
So comment there, lead to the specialist.
Ones that work, I'd be delighted to hear about it.
I was lucky to get mine on sale. It's a Dermlight pocket dermatoscope, and I think it's specifically for GPs. And yeah, I think it's pretty good. Any more questions? Okay, I think that's all of them. Thank you so much.
Cool.
Oh, one more, sorry. So related to what you said, is it right that GPs should be considered competent after one dermoscopy course and not using every day?
I don't know. I think it's quite a difficult skill, dermoscopy, and I tend to try and go on a course every year or so, although I'm using it several times a week. I don't know. I think one would need to try and benchmark oneself against colleagues or against looking in books or whatever, and probably keep up with repeated training, and ideally actually see lesions in the flesh in a dermatology setting, probably.
That's wonderful, thank you. There's lots of comments in the chat saying thank you very much. It's a fantastic presentation, really useful, excellent session. So, thank you, Dr. Swale.
So thank you so much, everybody, for coming, and thanks for that fantastic talk. I definitely learned a lot from that. So just to say, you'll receive a feedback form, so in the form of one of the mentee feedback questionnaires. So we'd be really grateful if you can fill that in online when you get that. And Michael, our faculty administrator, is going to send you all out a CPD certificate of attendance as well. And we look forward to seeing you at the next EASE event. So thanks everybody for coming.